If you are taking an antidepressant, antipsychotic, ADHD medication, anti anxiety medication, or some type of psychiatric drug, or you are considering getting on some mood changing psychiatric medications, I strongly encourage you to watch this full interview. Hey guys, my name is Judy Cho and I'm board certified in holistic nutrition. And I have a private functional medicine practice where we have worked with over 2,000 clients and patients get closer to root cause healing. I came across Dr. Mark Horowitz's work a few years ago when some of my clients shared how they struggled to get off their psychiatric medications. Actually, some of my clients got really, really sick and nearly lost their lives because of psychiatric meds. It was in the work of Dr. Horowitz that they actually had a lifeline and that honestly saved them. And so I have been trying to get Dr. Horowitz on my channel for a while because you'll see that he is a brilliant mind. And most of all, he is helping because he went through his own struggles with withdrawal from psychiatric medications. I hope that you take a pause and think about your current situation and the stuff that he brings up. And if in any way that the medications you are taking or thinking of taking are adversely impacting you. I didn't realize that this interview would get me so emotional, but it just reminds me of where I came from and why I'm passionate of sharing information so that people don't make the same mistakes that I did. Let's get right into the interview. Hi, Dr. Mark Horowitz. I am so excited to finally have you on. For the people that may not have heard of you yet, I'd love for you to introduce yourself and like why you got into psychiatry and the withdrawal of medications.
Sure. Lovely to be here with you, Judy. I'm originally Australian, although I work in England at the moment, and I'm a training psychiatrist, but I've taken a long break from my training to do research. I originally did a PhD in how antidepressants work and the neurobiology of depression at the Institute of Psychiatry in London. Um, I had a big change, I guess, in my career when I tried to come off antidepressants myself, and I had a terrible time with that. I'd been on the drugs. I've been on Lexapro or escitalopram, a very common antidepressant in America, of course. I'd been on it at that point for about, I think, 12 or 13 years. It was the end of my PhD, and I basically came across an article talking about antidepressant withdrawal effects. And I found that to be very startling because I hadn't been taught that this drug could cause withdrawal effects. Um, and I kind of had this idea that, well, drugs that cause withdrawal effects, have all sorts of issues with them. Number one being tolerance. So withdrawal and tolerance are kind of the flip sides of the same coin. The more you become tolerant to a drug, the harder it is to stop it. And that means that the drug wears off over time because tolerance means it has less and less effect, like caffeine or heroin or opioids. And so I thought, what is this drug doing for me after 13 years of being on it if it causes tolerance effects? I also thought, well, drugs that cause withdrawal like Valium or Xanax or Klonopin or OxyContin, have all sorts of other toxic effects usually. So I thought, how safe can this drug be? So it gave me a bit of a fright, and I started to come off the drug. And I was a diligent PhD student. And I went and read all the published papers about how to come off antidepressants, some of which were written by my professors because I was working at an institute at that point that passed Harvard as the most cited research institute in the world. So it was, the top people in the field were all around me. And their papers said withdrawal effects. They use a euphemism, discontinuation effects, which is sort of, to me, a bit like describing a car crash as a discontinuation event involving a wall. It sort of takes away a lot of the heat and light from it. The papers said that discontinuation effects were brief and mild, and you could come off antidepressants in 4 weeks. And I thought, well, that sounds pretty promising. And then I also went and checked Google, I guess being a millennial, albeit a bit of an older millennial these days. And there was a very different story there. There were people saying it took them months or years to come off. Some people said they got so sick coming off, they thought about taking their own lives.
Mhm.
Um, it was much worse than the issues that had put them on the drugs in the first place. Horrific stories, brain zaps, panic attacks, people losing work, people having their partners leave them because they were so unwell, really kind of nightmarish stories. And I was very confused at that point. I thought, I'm a fairly institutionalized person. I've got 6 academic degrees. I spent my entire life sitting in lecture halls listening to professors. On the one hand, they're saying it's brief and mild. On the other hand, there are people, hundreds of people saying it's not that. And I sort of decided to split the difference and come off over a few months, which was much slower than the guidelines said, which was sort of 4 weeks at the time, but not as slow as people on these online groups said. And I used the equipment from my molecular biology lab where my PhD was being done. So I was, I had access to sort of cutting edge technology. And I used liquids and I used pipettes and micropipettes and weighing machines. And I basically reduced my dose by about half every month for 4 or 5 months. And I started on, I think, about 10 milligrams of Lexapro. I ended up on 1 milligram, a very, much lower than the lowest dose normally prescribed. And at that point, my life imploded, basically. I had trouble sleeping. I would wake up in full panic, like I was being chased by a wild animal on the edge of a cliff, palms sweaty, heart racing, um, in full, fight or fright mode. And I would be in that state for sort of 10 or 11 hours of the day. I get a bit of relief in the evening. I felt dizzy. I felt like things around me were not quite real, like I was slightly stoned, but not in a fun way. And those symptoms went on week after week for several weeks. And it just wore me down. I thought, I don't think I can keep living like this. And the other thing is I thought this is nothing like the issues that put me on the drug in the first place. I had started this drug as a 21-year-old. I was a, existentially confused, unhappy, miserable 21-year-old, but I'd never had panic attacks or trouble sleeping, so this was completely out of proportion to what I'd had before. If what I had before was 3 out of 10, this was, 10 out of 10. And at that point, I basically went back to the drug, um, went back on the dose, slowly went up sort of milligram by milligram, week by week, and eventually the symptoms settled down. I ended up on the same dose I started on, maybe a little bit higher. Um, and the symptoms resolved, luckily, which doesn't happen for everybody, I should say, but they did for me. And at that point, I realized that I'm now on this drug, not because it's helping me, but because I'm trapped on it. I can't get off this drug because the withdrawal effects were so unbearable. I couldn't handle it. In that process, I just mentioned one other thing in my long answer to your question, which is I'd had a lot of health problems whilst I was on the drug. I had issues with the main issues that I had were daytime fatigue and memory impairments and concentration issues, which was very noticeable to me because, I'm a very academic person. That's what I spent my life doing. I had a brilliant memory when I was younger. That was kind of my USP, if anything. And slowly over the time that had really diminished. I was getting older, but I was certainly, I was in my 30s. It wasn't like I was over the hill, I don't think. But it had become really prominent. I had trouble remembering people's names, things at work, became embarrassing, to the point where I was even looking at getting, neuropsychological testing to see what is going on here. I had a lot of fatigue during the day. I would sort of find places to nap. I attracted various diagnoses from different doctors, chronic fatigue and then narcolepsy. And that had been in the back of my mind. I had this sort of thought, is this to do with the antidepressants at all? I wasn't at all sure. In the process of coming off the drugs, I'd read a bit more and I found a lot of people had similar problems. They were sleeping during the day. They'd been diagnosed with ADHD whilst on an antidepressant. They had all sorts of similar issues. And so when I went back on the drug, it was a very upsetting moment for me. Number one, I'd been really unwell. So I sort of having to retreat back to the drug was upsetting. But number two, I developed, the idea that the issues that I'd had on the drug were probably because of the drug, because other people had them. So now I thought, I'm back on a drug. It's probably caused me all these health problems for years. So I was very, I was not a happy camper when I went back to the drug, although I was relieved to be free of those withdrawal symptoms. And basically, since then, I have focused on the harms of psychiatric drugs and how to safely stop them, kind of having my eyes open for my own experience. And I should say, if it had just been me, I would have thought, look, I'm a very unlucky guy, it's just what bad luck. The fact that I found hundreds and then thousands and then eventually tens of thousands of people with the exact same issues that didn't match the textbooks at all made me think this is not just me as an unlucky bloke, but something wider than that. And so that's sort of what's led me to focus on this issue so intently.
Thank you so much for being so eloquent with everything you explained. I was telling you offline, but in our functional medicine practice, a lot of people have like the invisible illnesses, so they just don't feel well. And so many of them are then told to go to psychiatric care, and then they'll get on some type of antidepressant. Some people get on the antipsychotics, and I personally have been on them as well. And for some people, we find that they have similar symptoms as you. They have a really difficult time getting off. And some people, they get off safely and they seem to be okay. They're still struggling with some of the symptoms they've had. But why is it that some people seem to get affected more? And then what do you think is causing, these imbalances? Is it the serotonin, the things that they talk about of why we even get on these things in the first place?
I'll answer the first question first. So we know that there are risk factors for withdrawal, and you've already mentioned the most important one. The most important one is how long you've been on the drug for.
Okay.
So studies are becoming clearer. If you're on the drug for a few months, most people don't have trouble coming off. Not everybody. Some people can have severe trouble, but the averages are more likely to be in the mild range. Once you're on the drug for years, something close to most people will have trouble coming off. So and we know in America, for example, that half of people on antidepressants are on them for more than 5 years. So there's about 45 million people on antidepressants in America, about 1 in 6 adults, and about half of them are on them for more than 5 years. It's 20 million people plus. So a lot of people are at risk of these withdrawal effects. The second most important aspect is what drug you're on. So every antidepressant has a risk of withdrawal. There's no free ride, but some are more risky than others. And the 4 riskiest antidepressants are what are called SNRIs, that is duloxetine or Cymbalta, venlafaxine, called Effexor, desvenlafaxine, known as Pristiq, and then one SSRI, paroxetine, called Paxil in America. Those 4 have a bigger risk than any other antidepressant. But all these antidepressants, fluoxetine, Prozac, fluvoxamine, Luvox, Zoloft, sertraline, mirtazapine, Remeron, they all have risk of withdrawal. Sometimes people are told that a drug like Prozac has no risk, but that's not true. It has no risk if you've been on it for 4 weeks, but it has a significant risk if you've been on it for a couple of years. Dose plays some role, but not as big as people think. So higher doses have a higher risk, but a lot of people are told, oh, you're on a small dose. But in actual fact, what the doctors are often saying is you're on the smallest available tablet, which is not the same as a small dose. So, being on a low dose doesn't protect people. And then the last risk factor is if you've had trouble before, you're going to have trouble again. So you got to know there are going to be a lot of individual factors that we don't yet understand. Some people whose liver and kidneys chew through the drugs very quickly means they will never be exposed to very high levels in their brains. And that's got to do with a bit of people's genetics. There probably is a bit of variation for other genetic pathways we don't understand. So there is certainly a little bit of uncertainty. But to sort of put it to bottom line it, if you've been on a drug like Effexor for a few years, chances are you're going to have a very difficult time stopping. If you're on a drug for a few weeks, you might be okay. But I think that long-term users, I would always err on the side of caution and approach things very carefully, because you'll be the exception if you have no trouble.
So in knowing all of this and all of your research, would you even recommend anyone ever getting on these type of psychiatric meds? Because in our practice, we do have some people that say, well, I do feel a little better on them.
Yeah. So this is this is a very important point. Look, uh, I think people should appreciate a few things before they consider an antidepressant, and the things to consider are the benefits, the risks, the withdrawal effects, the alternatives, and also how the drug works. Actually, I think it's five things. So I'll just go through them briefly. Number one is actually let's start. I'll start with how they drugs work because that's I think that's often missed, and you sort of mentioned that when you talked about serotonin. So a lot of people are told that antidepressants for depression is a bit like insulin for diabetes. The idea being that antidepressants correct the chemical problem in depression. And that's a very compelling, narrative. If someone told me, you've got an insulin problem, do you want to take some insulin? I'd say, yes, probably I'd try diet as well, but that's kind of seems very convincing. And so it's a very compelling pitch to patients. And of course, that pitch comes from drug companies because, what the research shows is not that. The research shows that there is no chemical imbalance in depression. We put together all this research a couple of years ago in a very high-profile paper, where we looked at healthy volunteers and depressed people, and looked at levels in the brain, in their blood, different serotonin receptors, different genes, and if you put all the studies together, there's no clear difference between people that are depressed and people that are not depressed in terms of serotonin levels. And in fact, it was interesting to see the response from psychiatrists to that work, because what they mostly said was, we already knew this. This was just a line from drug companies. It was a bit of a metaphor. We didn't really mean it. We didn't say that. Everyone knows that's a simplification. I feel like the public did not get that memo, that they were not told that that was a simplification or a metaphor. I think a lot of people are walking around thinking they've got a chemical imbalance, but I think it's very clear that there's not. I'll just make it even clearer. We know that by the age of 45, 70% of the public will meet criteria for clinical depression or clinical anxiety. It doesn't mean feeling low or anxious. It means meeting the criteria in the DSM, the same kind of diagnostic test they'd use in the hospital. So number one, that tells us more of us will have depression or anxiety than won't, 70% of people. And it's not possible for 70% of people to have an abnormal brain, to have something wrong with their neurotransmitters. That doesn't make sense. So I think, that's the first thing, is kind of take a step back here. What is depression? Depression is not really explained best by looking at the chemicals in people's brains. We know from research, really, that I like to say that what my grandma thought causes depression, is correct. If I'd asked my grandmother, she would have said, people become miserable when life is miserable, and they become anxious when life is, uncertain or threatening. And that's what cutting edge research shows. The more stressful life events you have in a given year, the higher your risk of depression in the next couple of months. So, a stressful life event is divorce, job loss, death of a loved one, diagnosis of a physical illness. If you have 10 of those, your risk of being depressed is extremely high. If you have none of those, almost nobody is depressed. And so to me, even talking about chemicals in the brain is a little bit of what I would call a category error. If your mother dies, why are you upset? You're upset because you've lost a loved one, you've lost connections. Is it because your amygdala is firing more? No. Is it because you've got lower chemicals? You're sort of mixing things up there. That's a response to what's happening in your life. You're depressed because your mother died. You're not depressed because your amygdala is firing more. Maybe your amygdala is firing more, but that's because your mother died. Right. So I think there's sort of like, in our society, we're very impressed with technology and neuroscience. And I think it's gone a bit far, because people, you can see it on TikTok. You can see the youth these days, they've sort of been taught this language of neuroscience. I'm depressed because of my serotonin, and I've got this issue because of my dopamine. And I think it confuses people, because, if you've got a serotonin problem, well, it's obvious that you need a serotonin solution, and that's a drug. But if you've got problems with being bullied at school or relationship problems or your job is, unsatisfying, well, you've got relationship, job, and interpersonal issues. So once you start getting confused that you're dealing with chemical issues, you can kind of get stuck in the wrong area of your life. So in other words, antidepressants do not correct a chemical imbalance. First of all, there is not a chemical imbalance, so they can't correct it. So what do antidepressants do is the question. How do they work? And there's all sorts of theories about they affect inflammation, they affect stress hormones, they affect new neurons. Mostly that is based on animal studies. It hasn't been proven in humans. It's very speculative. But what happens, what is found in survey after survey is most people on antidepressants say the same thing, and that is they say they feel emotionally numbed, which means that their emotional range from very positive to very negative has been squashed into the middle. And you can see why that would be a relief for a lot of people. If you've got 10 out of 10 panic attacks, turning the volume down to a 3 can be a relief. And so when people say the drugs work for me, I kind of believe people. I'll talk about what the data shows, but I believe people when they say that. But I think it's very important to understand what work means. Because if you think, I feel less panic now because this drug has fixed the chemical problem in my brain, then you're probably not going to stop it, because why would I stop insulin for diabetes if I had very bad diabetes? If you think this drug has reduced my anxiety and depressed mood because it's numbed me, you might be thinking, okay, look, maybe I need that now because I'm in a pretty bad situation. It's probably not a great thing to have long term because it can cause all sorts of issues. And actually, it's the number one reason people come to my clinic in London, is the emotional numbing, because it affects people's sense of self. It affects, people say, I used to like art and sport, but now I'm not very interested. People say, I don't know what I think of my spouse anymore, because when you lose your capacity for emotions, it affects every aspect of life. So I, when I'm talking with a patient about whether they want to start antidepressants, I'm making these points that it probably works by numbing. I mean, that happens to 3/4 of people in surveys. So to me, until proven otherwise, that's the way the drugs work. People might choose it. People do all sorts of things, but I think that's worth having in mind. So that's the first thing: how the drugs work. I'll be briefer for the rest. Um, the benefits. So how well do these drugs work? It's pretty clear the answer to that question. There have been now about 1,000 studies on antidepressants versus placebo. And the punchline is this: depression is measured on a 52-point scale in these studies. Placebo reduces your depression score by about 8 points and antidepressants by about 10 points. So there's a 2-point difference between antidepressants and placebo on a 52-point scale. And people argue that that 2 points is an exaggeration for a variety of reasons. Number one, drug companies only publish positive studies. They don't publish negative studies. When you look at unpublished studies, there are as many negative studies. Negative means placebo and antidepressant had no difference between each other, as there are positive studies. So that is probably an exaggeration of the effect. People in these studies know they're on the drugs because they have side effects and other changes that let them know. We know that can lead to expectancy effects where they get better because they think, oh, I'm on a drug that's going to help me. And that makes people feel better. Um, and so some people argue that actually there's probably no real difference between placebo and antidepressant when you take into account those effects. And the last point is those studies go for 8 weeks. I mentioned tolerance at the beginning of this interview. Once you're on the drug for 10 years, tolerance effects are going to erode anything that it's done for you. So there are big question marks about whether antidepressants, have any real effect for people. The harms are numerous. I'll just run them off quickly. They cause weight gain. In short-term studies, they don't do that, but in long-term studies, they clearly do. They cause emotional numbing. They cause cognitive impairments. They cause memory impairments. They cause daytime tiredness. They can cause nausea. They cause sexual impairments in more than half of people. And that means an inability to orgasm, to sustain an erection in some men, or at least a reduced capacity. And we also know now, very disturbingly, I think, that some people who experience sexual side effects will not have them improve by stopping the drug. In other words, the sexual side effects persist after stopping. It's called post-SSRI sexual dysfunction, PSSD. It's been recognized on the side of the drug packets in Europe and in the UK. America has not yet put warnings on the drugs about it, but it's recognized in the rest of the world.
Of
And
course.
then, yeah, sorry, America, I think the FDA is actually currently being sued by a
Okay.
patient group and researchers for not addressing this issue. So people out there are pretty angry. I mean, you can sort of imagine there's a group of people in their 20s who went on this drug, for issues in their lives, sort of things I mentioned, whatever, bullying and university troubles, who have had their ability to have an erection as men or orgasm as women completely eradicated. And so, some of them have had this trouble for years and they're pretty angry about it because they weren't warned. And that's why there is so much, I guess, anger at the FDA at the moment that this hasn't been reported. Um, and then the last thing for older people, as you get older, these drugs can have a whole lot of health risks. So in studies that compare people on antidepressants to people who are not on them, there's an increased risk of falls, stroke, fractures, heart disease, cataracts, osteoporosis, and even an early death. And there's a debate about to what extent that's because of the drug or the condition. But for some of those effects, depression doesn't cause, a big increase in risk for cataracts or osteoporosis. So I think that it's pretty likely that these drugs are causing issues for older people. So it's a good reason to come off them before you get into that age group. And then the last withdrawal effects we can talk about a bit more, but they can be very debilitating. And the last thing is the alternatives. In the UK, the government guidelines for depression, which are much less corrupted than in America, I should make that point. The way that guidelines are written in America is illegal in the UK.
Oh, wow.
In America, what they do to write guidelines, things like the American Psychiatric Association, get together a group of psychiatrists, most of whom are paid by drug companies, and they recommend a series of drugs that are produced by the companies that pay the people on the guidelines. So it looks like a very commercially influenced process. In the UK, you can't have those sort of conflict of interests and be involved in the guideline committee. Or if you are, you're held out of the room for the section when you're talking about those drugs. And so the guidelines in America and the UK are like from different planets. America, you have a series of drugs for depression that are recommended. In the UK, there are 21 treatments that are said to be equally effective and cost effective for depression, and 3 of them involve antidepressants, and 18 of them involve mindfulness, different forms of therapy, exercise. In fact, the most cost-effective treatment for severe depression is problem-solving therapy, which means getting people to write down their top 3 problems, what the next step to do for each one, coming back and reporting on progress or barriers to acting on it. In other words, help people to solve the problems in their lives. People have pointed out there isn't much research in diet or in exposure to nature. So a whole lot of things have not been studied and therefore didn't make it into the guidelines. But other research suggests that all those sort of things can have as much or more of an effect as drugs. And so there's a whole range of alternatives. So to me, there's sort of a drug first culture, especially in America. I think it should be the other way around. You should exhaust every other option that's offered to you, and drugs should be last, not first. There are cost issues about that. There's system issues, but I think that's what the evidence says is the best for every person. So I think those are the sort of things that I would talk through when people are considering starting an antidepressant, and then talking about how hard it is to stop it. It can take you months or years, and it may be so difficult for some people that they're unable to stop it. And so some people should be aware that if they start an antidepressant, they may never be able to stop it. So I think those are all important issues.
Gosh, just hearing everything you bring up, it's so maddening because even I was on an SSRI and I wasn't on it for more than a year. And but I remember distinctly. So I was always really social. And I went to Los Angeles where my brother lived. And I remember distinctly, I was just like staring out of the car window. And my brother asked, "Is everything okay? Because you're so muted." That was exactly what I was going through. And for some reason, for me, my behavior, so like the eating disorder, was not improving with the antidepressants. Yes, I absolutely felt muted. So I stopped crying. I stopped really laughing as well, or getting super upset. But the eating disorder part never went away. So the habitudes. And so all my psychiatrist did was let me try this antipsychotic and this one.
Yeah.
And some of them, like you said, would make me gain weight. And that would be my biggest fear. And so it's so upsetting knowing that that is actually such a common symptom, the muting. And we think, well, I feel better now. And it's like, no, we're not getting to the root cause of your issues of, if I work on my eating disorder, what I'm using my eating disorder for, maybe my depression would go away. And I think a lot of people struggle with that. Like you said, maybe it's that people are getting bullied, or something in their life isn't working the way it should. And so we
Yeah.
get emotional, we feel bad, we don't like the way we feel. And instead of fixing, hey, go out and fix the thing, like the problem solving solution that you brought up, instead it's, here's a band-aid. Everyone's on anxiety. I just talked to one of our clients who's around 23, and he said every single one of his friends is on an anti-anxiety medication. And you just wonder, what is the harm in the next generation? And it's so upsetting because it's so normalized that we should feel this way. But it's like you said, there's so many other things in our practice. We don't see getting on antidepressants or getting on these psychiatric drugs being the solve for their issues. And yet we don't have people that share these things and all these nuances of even the UK and the US, and it's super upsetting.
Yeah. Yeah. You make some really, really important
Yes,
points.
please.
So I just want to say, I think you're exactly right. Taking these drugs doesn't get to the core issue. To me, I think it actually can make things worse as well, because, you sort of said, it's a signal. I think your emotions are signals. They're not. I
Yes.
think that we've sort of reclassified emotions as illnesses. I think that makes sense. You're upset because your emotional needs are not being met, because you're overwhelmed. To me, exactly, it's like putting a band. The light goes off in your car, replace oil, you put a band-aid over it. That's not helpful. That'll cause trouble. I think
Yes.
that's much the same when it comes to our approach to emotions. I would give anything to go back and have the pain that I had when I was 21. That the pain that I had when I was 21, was about my life choices, about, what I wanted to do, versus the incredible, much more severe issues that the drugs have caused for me. So I think that's true for a lot of people. Sometimes it sounds like I'm giving tough guy advice. You got to, go through the tough things. I just think that's, a bit, life. I mean, I don't want people to have painful experiences, but if you don't, solve the issues that are causing it, it's going to recur.
Right.
And so taking, an eating disorder, we know that dealing with any mental health issue is kind of about, getting to core issues. And drugs impair that in two ways. One, whether it's therapy or some kind of more organic process, getting to the core of it is about facing difficult emotions. If your emotions are numbed, you're lacking the material to deal with. Two, it's also about, thinking differently. And if drugs are causing a bit of cognitive impairment, it can make it harder to think straight. So, I think I know a lot of therapists who say it's almost not worth dealing with people that are on the drugs because they can't do the work. And they much prefer people to come off the drugs before doing therapy. So I do think that's important. And the last point is, there is now an emerging literature that these drugs can make people's emotional lives worse. They call it tardive dysphoria. And it basically refers to people who are on drugs long term, whose depression and anxiety gets worse on the drugs. And that sounds very strange to people when they first hear it. But if you think about it, these drugs can impair sleep. That can make people more emotionally labile. If it affects memory, that can make people's lives more difficult. There are all sorts of ways that taking drugs that have, a lot of side effects that can cause more trouble. So I think, I share your concerns that this is that young people are being, doused in drugs that aren't solving their problems. And if everyone in a classroom, is anxious and needs a drug, better to be asking what's happening in their social life, their world, rather than having to give drugs to every single person. So it is worrying.
Hey guys, just a really quick interruption. If you notice, we don't really run ads on this YouTube channel. And just being fully candid, instead of making money on external sponsors, we really wanted to share more about our functional medicine practice so that if you ever need it, you know that what we offer and what we can provide in terms of service and products. If you didn't know, our private practice has one-on-one sessions. We have packages. We do group calls with SIRS and with mind body or nervous system regulation. And we also do a lot of functional tests. Some people do a complete wellness panel with us. So once a year, they get a detailed, comprehensive blood work to see how their health is doing. We also do functional tests such as stool tests to see if you have parasites or candida or H. pylori. We also do a lot of the Dutch urine as well as saliva tests to make sure that your hormones and thyroid is functioning well. Our flagship is our symptom burden, where we really trust the innate wisdom in our bodies. And so we are trying to see what symptoms do you have, because oftentimes a combination of symptoms is related to a specific system. We focus on gut health, where we try to get people's gut healing, because most of our immune system is in our gut. If you make your own body stronger, you will be a lot more resilient to everything that is in our toxic world. We believe in wellness for all, and not everyone can afford to work with us. So we provide a lot of free guides, free ebooks, free downloads, free tactical things to get you healing in your wellness journey. We also write comprehensive, detailed articles. For example, why a carnivore diet may have lower T3 markers, but may be in fact okay. I hope that the content I share is enough for you to get healing. But if the needle is not moving enough with a carnivore diet, with lifestyle changes, with mind body work, if it's not moving enough when you are working alone, just know that we have the services to support you when and if that day comes. Because we are holistic health, we also have a prescriber. So if you are on thyroid medications or hormone medications, or you need medications for SIRS, we are able to walk you through the process. Our goal is to get you off most of your medications. All right, guys, thank you for being part of this community. Let's get back into the video. Would there be a need for psychiatrists then, if that's not the first thing that we should be taking, is getting on medications for whatever thing that is not going right in our lives or that's making us emotionally unwell? What is the need of a psychiatrist?
It's a very good question, Jody. And I think that's why, I think when you start talking about the harms of these drugs and the fact they're not very effective and they cause a lot of people trouble, psychiatrists become very defensive because, it's the same response as people working for a fossil fuel company get to talking about climate change. They can see that this problem ends in there being less business. And I think that's obviously true for psychiatrists. I think that I think we should have a demedicalized approach to mental health distress. And I think that does mean, that psychiatrists are not so central in the mental health system. And I think that makes psychiatrists nervous to hear that, which is why they push back on this sort of research and this kind of work, because it's very challenging to them. I think psychiatrists have a role in helping people to stop drugs. I think that deprescribing, the kind of work that I do. So if there's a young psychiatrist out there, I'm saying there's lots of good work to be done, which is to kind of turn the supertanker around with all this prescribing back to more rational levels. I also I think there is some role for psychiatric drugs. I don't want to throw out, the baby with the bathwater. I think that the way that drugs can be helpful is if you recognize what they're doing. So, sometimes band-aids are useful. Sometimes numbing is useful, especially for more severe conditions. I think that there's a role for drugs that do mute people a bit when they're having experiences that are very dangerous.
Okay.
But I think that in general, it's better to use things shorter term. It's better to stop. It's better to have a plan to stop when you start things, and it's better not to mistake drugs as cures. To see them as band-aids. So I'm not against using band-aids in medicine or using casts. But if you start mistaking those as cures, then you cause people problems. So I think there's a role for psychiatric drugs. I think it should be much more contained. I think they should be thought about in a different way. But I still think I don't think they're completely useless.
When I met with my psychiatrist, I asked at a certain point, because I was working with him for a few years, and I know that for sure they make a lot of money. I think I would meet him for 10 minutes and I was paying out of pocket like $250 just to continue my medication. And you can imagine there was always people in his waiting room. But I think one thing I asked him was, does nutrition or diet play a factor? And he looked up and he said no. And now knowing what I know, there are deficiencies that get impacted by taking these medications. I think folate's one, B12, magnesium, and I'm sure there's a lot more. And so I can see the downstream effects of when you've been on this for so long, you're probably not getting all the nutrients you think you are getting when you're taking these medications. A quick question. You said when you get older, there's higher risk. Like, what do you mean? What is older? What's the age that you're referring to?
So the studies that I'm talking about, they look at older adults, and older adults are defined as people that are over the age of 65,
Oh, okay.
and they're looking at specific health outcomes. But of course, it's not like these drugs are completely benign up until the age of 64 and then they become bad at 65. I always think this is basically showing in a kind of sensitive population what the drugs can do. So to me, it doesn't mean you should stop at the age of 65. It means you should stop, if you can, earlier, so you don't encounter these issues as you get older.
If people are listening to this that are on some type of psychiatric drugs, whether it's anti-anxiety, antidepressants, and now they're sort of concerned because I think if people take a second and think about, I'm on an antidepressant, is my life or mood a lot better? And I think most people will say not really. So how do they start? What should they do to start, like, okay, I need to wean off this, especially that I've been on it for years and I don't want to be the population that is having these severe withdrawal symptoms?
Yeah. So great question. The first thing I would say is, if you listen to this podcast or you're unsure about your drugs, the number one thing is do not stop your drugs abruptly. That's the most dangerous way to stop them. Do not do that. It would be better to talk to a physician about how to do it. Only issue is it's very hard to find a knowledgeable physician about this because they've been taught, like I was, that it's mild and brief and can take a few weeks to come off. If it happens that I work with a clinic in America called Outro that runs a service in California, in Colorado, and Washington State. So if you want to go to people that know what they're talking about, they're worth going to. If you go to your local doctor, I'll give you a quick outline of how to come off the drug. You can kind of ask them, what do they think of this? And that'll give you a sense of their level of expertise. Because there is starting to be, I think, a little bit more awareness among some doctors. So if you're lucky, your doctor might know about it. But I would say for the vast majority, they don't know about it. There's basically three main principles to coming off these drugs safely. The first one is you've got to do it slowly. And slowly, is different for different people. If you're on Effexor for many years, slowly will probably mean years to come off it. It means 2 years or more. If you're on it for a few months, then coming off it, you might be able to do it in a few months. But the answer is it's not measured in days or weeks, it's measured in months or years. That's the first thing. And that's to give basically enough time for your brain and body to readapt to the drug not being there. I sort of think tapering, which means coming off the drug slowly, is a bit like coming down from the top of a building. If you jump from the top of a building to the bottom, it's going to end very badly. If you walk down step by step, it'll take you a lot longer, but you won't cause so much trouble to yourself. And that's what tapering is. Tapering means coming off a drug step by step. The second principle is, I've talked about the risk factors for coming off, but there's a little bit of uncertainty. And so there's a bit of trial and error involved. Everybody has to kind of work out what rate suits them. And the example I'd give is something like altitude sickness. So if you go up too quickly on top of a mountain, people experience altitude sickness. Everyone's a bit different. And, you got to take a bit of feedback from that. So if you're getting sick from altitude sickness, you've got to slow down. In other words, stay where you are and get used to the altitude, or go back down a bit and then come up more slowly. It's the same for coming off these drugs. If you experience withdrawal effects, it means pause, go back a step or two, and then come down more slowly. So you're finding a rate that you can tolerate. Some doctors will jump to the conclusion that if you have withdrawal effects, it must mean you need the drug. But that doesn't make any sense. That's like saying to a smoker, well, you feel really anxious and irritable, so that means you must need to keep smoking. Otherwise, you'll get anxious again. That doesn't make sense. What makes sense is you need to come off it more slowly. The reason why it's more complicated for antidepressants than for cigarettes is, it's more confusing as to what is a return of someone's condition and what is withdrawal effects. But I would say for most people, withdrawal is much more likely than a return of their condition. The reason for that is most people's condition relates to the circumstances in their lives. So People get depressed when they've got a lot of work pressure or divorce. It's very hard to have a relapse of divorce when you come off your drugs. A return of divorce is the sort of the language they use. So, most people do not have these sort of severe recurrent disorders. Most people on these drugs have mild or moderate conditions. Most people don't have suicidal depression that put them on the drugs. And so if you have symptoms coming off it, it's much more likely to be withdrawal effects than it is to be relapse. That's the first thing to recognize. There's also a few little clues to help people recognize that. Things like headache and dizziness and brain zaps, this kind of sensation of a little bit of electricity in people's heads, um, you know, are very typical symptoms of withdrawal, and that can help you say, look, this is not really anxiety or depression, this is withdrawal. So there's that trial and error, going at a rate you can tolerate. And then the third point is actually, if I can share a graph, this is a
Yes.
video,
Oh,
so
yes.
I guess some people will probably be listening, so I'll try to describe what I'm showing, so I've taken an example of citalopram or Celexa. But what I'm showing for Celexa is true for all antidepressants. And what I'm showing is neuroimaging, so brain imaging of people taking this drug. So there's dose of the drug on the x-axis, and the most common doses given in America are 20 milligrams and 40 milligrams. And the y-axis is actually effect on the brain. It happens to be about serotonin, but it's effect on the brain. And the key point about this graph is it's not a straight line. So that doubling dose from 20 milligrams to 40 milligrams doesn't double the effect on the brain. In fact, it's only a small increase.
Mm.
And a tiny little dose, like 2 milligrams, actually has about half the effect of 60 milligrams. It's
Wow.
quite surprising. The smallest tablet in America is 20 milligrams. So doctors might laugh at 2 milligrams,
Right.
but it has a bigger effect than you would think. And this allows us to understand what happens when people come off these drugs. So most doctors, if you say, I want to come off 20 milligrams of citalopram, first of all, they might say, well, why would you come off it? Because you wouldn't come off your insulin. But if they did agree to come off it, they might say, well, let's go down by 5 milligrams every week or so. So go from 20 to 15, 15 to 10, 10 to 5, 5 to 0. And it makes sort of logical sense. You can do that by dividing a tablet in half, take it every second day. It's easy for the doctor. It's not easy for the patient, though, because the first reduction causes a very small decrease in effect on the brain. The next one, twice as big. People can find that quite unpleasant. The third one's even bigger. And the last one, from 5 milligrams to 0, is like jumping off a cliff.
Wow.
If you imagine this as like walking down a path, it starts off as a garden path, turns into a steep hill, and then into a cliff. And if doctors are not aware of this relationship, they will think that the person's relapsed, they've had a terrible illness. At the end, they must need the drug. But actually, what's happened is this last reduction has caused a very big change in effect on the brain. And so what makes more sense is, and sorry, that's exactly what patients say. Patients say the first few milligrams are easy to come off, the last few milligrams are the hardest. What makes more sense is to reduce the drug in such a way that it reduces effect on the brain
Mm.
by an even amount every time. So I've drawn 4 horizontal lines here. And so in order to have this change in effect on the brain, you need to go down by smaller and smaller amounts, down to very tiny, tiny little doses before stopping. So that going from this tiny little dose to 0 doesn't cause a bigger effect on the brain than these previous reductions. And this is because this shape is called a hyperbola. This has been called hyperbolic tapering. This is what we do at Outro Health. And this is also, I wrote a textbook on this topic that kind of explains to doctors and also to patients how to come off these drugs safely, that kind of goes through this for every single drug on the market. And of course, the big issue is, how do you make up these small doses? Because the smallest tablet is 20 milligrams. And the answer is you can do some things with splitting the dose, splitting tablets in half or quarters. But really, for a lot of people, to get these very small doses, you need to get some kind of liquid version of the drug, which is available for quite a lot of antidepressants in America. Or you can go to a compounding pharmacy to get a capsule or tablet made up. And so this is the test for a doctor. If you go to see a doctor and ask, I want to come off an antidepressant, do you know much about it? If you ask them, do you use anything other than tablets to come off the drug? If they say, no, 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 you'll be fine with just the tablets, then you know they don't really have a good idea of how to come off the drugs. Because for most people, that's long-term users, you'll need to use something other than the tablets, a liquid, compounded capsules, to get off the drug safely. So that's sort of my litmus test for a doctor if they know what they're doing. They say, oh, you'll need to use a liquid and be slow and go to rate that you want to go at. They sound golden to me. But otherwise, you might want to look for a more experienced doctor to help you out.
It's so fascinating when you brought up the last dose because that's exactly where our clients struggle from getting off. So they'll eat a carnivore diet or clean up their diet and they start to feel better. And so they're like, I want to get off my antidepressants or whatever medication I'm on. And so they start going down, but it's always the last part of the dosage where they're like, I need to go back up. And so that's always the thought. And I never realized that connection with how much it impacts your brain. And so no wonder it does that. And recently we had a client that said they went to their psychiatrist like, I'd like to taper down, and they said that their psychiatrist never learned that in school and it's never been a thing, that they've never been taught to, like, eventually you need to or here's how to wean your patients off. Like they don't know how to do that.
That is absolutely right. I mean, my gag is the first lecture that I had on how to safely stop a psychiatric drug that I heard, the first one that I heard was the one that I gave. In other words, I didn't get a single lecture in all of medical school, in all of my psychiatry training about how to stop the drugs. I was given hundreds, if not thousands, on how to start the drugs. It is absolutely not a part of our training. And so, to me, that's crazy. It's like selling cars without brakes, but you're right. But most doctors don't know how to stop it. I spent years of my life, just to share one more picture. I spent years of my life writing a textbook that explains to doctors how to come off the drug. It's called the Maudsley Deprescribing Guidelines. It's available in America. What I found a bit upsetting about it is a lot of patients have bought it for their doctors. I think that's not the way that medical education should function, but because people are desperate, they've either try to use the information to work it out for themselves, or they've given it to their doctors. I spend a lot of time now lecturing about this, but if people want to get that, it'll give you at least a guide about how to come off the drug. And some people say, look, I want to do this to my doctor. And because it's written out there for them step by step what to do, some of the doctor will say, right, we'll do that because it'll make their life easier.
Okay, well, I'll put all of that in the show notes. A question about ADHD medication. That's another one that's coming up a lot where a lot of people are taking it. What are your thoughts about that medication?
Look, very briefly, I spend a lot more time looking at antidepressants than
Sure.
ADHD medications. I think a lot of things are similar. I think
Okay.
any drug you take, your brain will become used to it. That causes, tolerance effects. When you stop the drug, you get withdrawal effects. I think in general, stimulants, the sort of amphetamines that they give for ADHD are easier to stop than other psychiatric drugs. I think they sort of don't have as much trouble with withdrawal, but that's not to say they're easy. People still can take months to come off them. So the same issues arise, the same principles about coming off at a rate you can tolerate.
Okay.
The last 2 milligrams are harder. Exactly the same graphs apply. And again, going back to what is ADHD, what causes people issues. There's this huge, there's an explosion of diagnosis in this
Yeah.
area. That's a lot because there's been a lot of promotion by drug companies about the diagnosis has now caught on, so that there's sort of a self-perpetuating thing happening on social media. People have concentration problems for all sorts of issues, because of trauma, because they're being asked to do too much in their jobs, because schools aren't set up to help people with different learning styles. So again, to me, there's a drug first culture. I think it should be the other way around, that drugs should be the last option because there are all sorts of, I sort of think it's presented as a quick fix. I think if I had to say, one point, quick fixes can cause long-term problems. So, I would do anything you could, if there's diet, exercise, ways of rearranging your work or learning to deal with concentration issues. That would be what I would lead with, and use drugs as the last option. And they can be, not so simple to stop as well.
When I was given the antidepressants, I think I was in a place of desperation that it gave me hope in a way of maybe the lot in life I had would change.
Yeah.
So people that are struggling, what's like the first tool that you would recommend?
Yeah. I'm sorry to hear you went through that. I mean, I think that's so true for so many different people. People start drugs at the most desperate point in their lives. And so, they're looking for a straw to clutch, and this is the one that's offered to them. Um, I'd say a few things to people in that situation. I guess I was in the same position as you were when I was 21. I was desperate as well. I think the first thing to say is, things pass, things change. They obviously did for you. It sounds like irrespective of the drugs.
Yes.
Recovery rate from depression at 12 months for severe depression that is severe enough for people to go to hospital with. So this isn't just, the blues, is 85% at 12 months. People that means people readapt in their lives. They whatever they find a new partner, they find a new job, they find some sort of something changes in their lives. So I think the first thing is to say, you know, when I say you should be hopeful, it's not because I'm a rose-tinted Pollyanna person. I'm the opposite of that. It's what happens. People get better over time. That's as you get older. And I like to say to people, being a teenager and being in your 20s is a very difficult condition. Which is only terminated by being entering your 30s. So it is hard to be a young person. There's lots of pressures. There are a whole host of things that can be helpful. From talking about your problems is the first thing. Before you even, I don't want to be this sort of guy that says, look, the answer is mindfulness and going for a jog, because that's a sort of simplistic one size fits all. I think what helps people is dealing with their problems. If that is about relationships, or that's about financial issues, then it's about dealing with those issues, which doesn't mean it's easy to do. I'm not saying there's a magical wand, but I do think that we shouldn't get lost in chemicals and drugs, and really think about a big solution to people is people around them. Reaching out to community, reaching out to people who have had similar problems. I've sort of seen on someone has a blog, 117 things to try before trying psychiatric drugs. So I can't list them all, but I would go through everything that you've heard about with the expectation that things generally work, and that desperation. In the moment, we often feel much more desperate and much more catastrophizing than is really the case.
Yes.
So I kind of my message to people would be to keep going and try things, and don't be unnecessarily hopeless.
Well, thank you so much. This conversation was so powerful, and I think it's a lot of information that people actually don't know. So that's the reason I wanted you on so badly. So thank you so much. Where can people find, and I'll put it all in the show notes as well, but where can people find your work? I know you've published a lot of studies as well. So where can they find everything?
So I've got a pretty dinky website at markhorowitz.org, where all my papers are. I'm on Twitter at Mark Horrow. I've written the Maudsley Deep Prescribing Guidelines. A lot of what I said is in that book. I work with Outro Health in America, and those are the main places to find me.
Well, I just want to take a moment and thank you. I know for sure you saved a few of our clients' lives. So, you could have just come off the drugs yourself and learned about it and not really done much. And the work you're doing is so important, and it's truly life-saving. So thank you. Thank you for the work you do. I applaud you for it.
Thanks, Judy. My colleagues don't have such kind words for me these days. So
no, I'm sure. I'm sure. Well, thank you so much for your time again.
Okay, love you.
Bye-bye.
Bye-bye.
Bye. Okay, guys, I know that this isn't the easiest interview, but I think it's so powerful in the information shared, the tactical tools that Dr. Horowitz brings up. And so that if you are taking some type of medication, there is hope in getting off these meds. I will link to the book, the protocol, the recommendations he gives in trying to wean off these medications. It probably is best to work with someone and not try to do this on your own. You also will need a real tool to get healing, that maybe you have been using a psychiatric med as a band-aid. None of the solutions are super easy in trying to get out of a mood imbalance or depression. And trust me, I get it. They diagnosed me with major depression. But I promise you, if you do the work and you do the hard work consistently, you can free yourself of these mood imbalances. It is not that we are missing a drug, that we're not well. It is usually something deeper. And our society teaches us that we shouldn't be doing that hard work. But I assure you, from even my story, that full healing is possible. And just know that there is always ways that we can heal and heal for the long term. Thank you so much to Dr. Horowitz for being an incredible person and putting out this work so people can save their lives. Okay, guys, make sure to eat a lot of meat. Take care of your bodies, because it is the only place you have to live. I will talk to you later. Bye, guys.